I'd like to go ahead and introduce you Barry Friedberg. Barry Friedberg is best defined as by his motto, measure the brain, preempt the pain, and medic drugs, abstain. That's really his, basically his big message, which is quite a bit. I've known Barry for many years. I scholar with Nick Isse several years ago in Los Angeles, learned from him how to do endoscopy, etc. And he was an anesthesiologist. I was very impressed how the patients, how well they did. You know, 2, 3, 4 hours of anesthesia, patients be wide awake, alert, ready to go home, no pain. I was most impressed, no nausea, just great. And I brought that message back to Honolulu. I told my anesthesiologist, and she practices that, and I've been very satisfied. He has a book that's being translated into other languages. The Portuguese version just came out. It's called Anesthesia in Cosmetic Surgery. I think there's some editions there. Some of you are interested. They're hard to find because they're very quite a bit on demand. So, without further ado, I'd like to have Barry come to the podium and tell us all you know.
Thank you. Thank you very much.
I'd like to say that Barry flew from California just for this presentation, and he's going to fly back. That's awesome. Thank you.
Thank you. Okay, well, first let's start with a quick disclaimer. Neither myself or my foundation, Goldilocks Anesthesia Foundation, get any money from Aspect Medical Systems, which is now Covidian, or any other maker of brain monitor or any drug manufacturers. We have a quick slide from Ziggy that says, partly cloudy tonight with a paradigm shift in early tomorrow. And because no compliment is too big, I'd like to quote Dr. Parsa when he says, PK anesthesia is a powerful solution that raises the standard of care for patient safety in outpatient anesthesia. Thank you so much. The essential elements for propofol safety is that somebody has to watch the patient. As I was telling one of my colleagues today at lunch, if you have an anesthesiologist who's coming in sleeping during the case, it's the patient who's supposed to be asleep and not the anesthesiologist. Also, a pulse oximeter of all the other monitors, vital signs monitors we have, is most essential because it gives you a warning of respiratory insufficiency. And also, as I'll tell you very shortly, I believe that brain monitoring is really the essential standard of care for giving propofol as safely as possible. And we all know what killed Michael Jackson. He had none of those three. Nobody was watching, nobody had a pulse ox on him, and he certainly didn't have a brain monitor. So how do you make your anesthesia as safe as possible? I'd invite you to share my vision. As Dr. Parsa quoted me so nicely, measure the brain, preempt the pain, and emetic drugs abstain. If you share my vision, you want to use minimally invasive anesthesia for minimally invasive surgery. And I stole the phrase minimally invasive from you gentlemen, so I thank you very much. And I like the expression minimally invasive anesthesia so much, I went ahead and trademarked it, so if it should catch on, people will know it's me. And I'm not going to read this slide, but minimally invasive surgeries include a great deal more than simply cosmetic procedures. You can do gynecologic, orthopedic, urologic, general surgery, neuro, sedation for morbidly obese, and yes, even our military is using this technique in the battlefields of Iraq and Afghanistan because they don't need an anesthesia machine or large quantities of oxygen. Did we go backwards? Yes. Okay. So clearly PK anesthesia, which is propofol ketamine, is not only for cosmetic surgery. I think we're going back. Here we go. All cosmetic surgeries are minimally invasive. Every procedure is extracavitary. Now, I understand that many of you feel that abdominoplasty is a major invasive procedure. I will agree with you that it's major in terms of the extent of the dissection, but the fact that it's generally extraperitoneal, at least by design, would certainly lead you to conclude that, yes, this is an extracavitary procedure. The other thing I wanted to say is my patient safety record. In nearly 18 years and over 5,000 patients of more than 100 different surgeons, all cosmetic procedures have been done with PK anesthesia without a need for general anesthesia. We do them supine or prone, or if they need to rotate over in the middle, it's not a problem for airway management. There have been no hospital admissions for postoperative nausea, vomiting, or pain. There have been no pulmonary emboli, even though we don't use sequential compression stockings. There have been no airway disasters, no aspirations, no difficult, unanticipated intubations because nobody's been intubated in 18 years. There's been no malpractice litigation. I've not been named in a single suit because propofol, as Michael Jackson taught us, is a happy drug. People don't like to sue people that they like, and everybody's had a good time with Dr. Friedberg. The postoperative nausea and vomiting rate is the lowest rate in the literature, and the interesting thing is that Dr. Athel is the one who defined high-risk patients, which is basically our practice. These are non-smoking female patients who often have a history of motion sickness or previous nausea and vomiting. They're having cosmetic procedures, and despite my best attempts, some of my colleagues still insist on writing for Vicodin for post-op pain instead of Darvocet. And because no complement is too small, it bears repetition that Dr. Parsa said that PK is a powerful solution that sets a higher standard of care for patient safety in outpatient surgery. Thank you again. Why monitor the brain? Well, Willie Sutton was a bank robber, I believe, in the 1920s, and they once asked him why he robbed banks. He says that's where the money is. The drugs we give in anesthesia medicate the brain, so it's pretty obvious that you want to measure the drug, the organ that you're medicating. And again, this was a reference I found as I wrote this textbook in 2004. It's a reference from 3 years earlier that says that the difference in propofol metabolism varies by as much as 19-fold in individuals. So there's no formula that you can get based on predicting blood levels or brain activity that's going to suffice for measuring the actual activity in the brain. Propofol also measures independently of the effects of the benzodiazepines or ketamine. So as in Michael Jackson's case, if they were able to measure the propofol, they would have been able to stay this side of what would have kept him from breathing. This is a reference that I included here because people would always say, well, you can't use a BIS monitor if you use ketamine, and I said, well, here it doesn't really change. So BIS is the prototype, but there are several other monitors. The foundation is not really interested in promoting the use of any particular monitor, nor am I. The idea is still to measure the organ that you're medicating. This is BIS 101 for those of you who don't know about BIS. It's a unitless index from 0 to 100. Awake is 98 to 100, and minimal, moderate, and deep sedation there are scored numerically. And they're in white because basically propofol ketamine is 60 to 75. General anesthesia, I have an asterisk there because propofol only to this level does not define general anesthesia. You must have systemic analgesia, so somebody has to give some fentanyl or morphine or Demerol intravenously to make propofol at 45 to 60 general anesthesia. Less than 45 defines over-medication, which is not good, especially for our senior citizens. Now, before I shock you too much, I just want to present the idea that office surgery is often a little more casual than many of you have been used to. This is a dental sedation patient. What you don't see is an anesthesia machine with malignant hyperthermia triggering agents. You don't see benzodiazepines, narcotics, muscle relaxants, or antiemetics, polypharmacy. We have EKG monitoring available. The nasopharyngeal airway is not on the field because he didn't need it. There is an AMBU bag as well as a crash guard and a defibrillator, so we have defined the elements of safety. What you do see is a sleeping patient who's safe, numb, and amnestic in the range below 75. He's breathing spontaneously. I am giving him some supplemental oxygen. And all we're really titrating is a single respiratory depressant to his specific brain activity. And suction, of course, you can see, is readily available to a dental office. Well, a lot of people tell me that their anesthesiologist tried this device before and said, gee, it really didn't help them very much. And that's exactly the problem, because what I advocate is an off-label use of the device. This is what it looks like if you're using the device in its most effective manner. The lower trace is essentially the electrocardiogram with the frontalis muscle. It's instantaneous. And so that means there's no surprises during the case. Using the monitor like this is the difference between trying to drive your car down the street with only the information you get in the rearview mirror versus the windshield. So if you look carefully here at 1700, you see a spike in EMG. And that is the patient's way of saying ouch before they wake up to the point where they can actually say ouch. So the treatment at this point is to give some more propofol. And in doing so, as you see, the yellow trace stays within this band, which is what we're defining as a good place for the patient to be. But what we're doing here is basically creating a video game to entertain the anesthesiologist, but also, well, I shouldn't say entertain, to retain, to more actively involve the anesthesiologist in the conduct of your case.